Welcome to the deep dive. Today we're really aiming high. We want to get to that elite professional mastery level for the structure that lets us interact with the world, the upper limb.
That's right. We're digging into the surgical anatomy using some pretty advanced clinical texts as our guide.
And when we talk about the upper limb, it's more than just an arm, isn't it? The sources frame it as this: articulated, coordinated masterpiece.
Exactly. The whole point, the design philosophy, if you like, is about positioning and manipulating the hand. It's all geared towards that incredible precision we have.
That precision and the sheer mobility. The texts really emphasize the freedom you get from the shoulder joints, the thoracoscapular and glenohumeral joints.
Yeah, they work together with the elbow and wrist, and suddenly your hand can reach almost anywhere in this, well, this sphere of reach around you. It's quite something.
It really is stunning engineering.
It is. And that's our mission today, isn't it? To unpack exactly how it all fits together. If we want to master this, we need to go deep on every part.
So what's the plan? How are we breaking it down?
We'll look at it in layers, essentially. The protective outer bits, skin and fascia. Then the scaffolding, the bones and joints.
Okay.
Then the engine, the muscles that drive it all. And finally, the infrastructure, the nerves and blood vessels keeping it running.
Right, let's start peeling back those layers. The protective shell first. Skin and fascia. From a surgical view, just knowing how the skin varies is crucial.
Oh, absolutely. It's not uniform at all. You look at the neck and the very top of the limb, the skin's pretty thin, very mobile.
But then compare that to the back of the neck, the shoulder, arm, forearm. It gets thicker there, right? More hair, typically.
Yeah, more protective where the movements might be, well, less about fine touch and more about power or just general movement. But the hand is where it gets really specialized.
The palm, specifically. That skin is something else. Thick, no hair at all.
And critically, it's anchored, really firmly fixed down to the palmar aponeurosis underneath.
That's key, isn't it? Stops the skin sliding around when you grip something. Essential for a solid purchase.
Absolutely. You wouldn't want your skin bunching up when you're trying to hold on tight. Then you flip the hand over.
And the dorsal skin is the opposite. Thin, much more mobile it has to be, to let your hand flex and make a fist.
Exactly. And you can actually see evidence of this deep fascial anchoring elsewhere, too. Think about the skin creases.
Elbow, wrist, the lines on your palm.
Right. Those creases are basically visual maps showing where the skin is tethered right down to the deep fascia below. It's not just loose over the top everywhere.
And we should probably mention the axilla, the armpit. That skin needs incredible mobility.
It does. To allow for that huge range of motion at the shoulder, the skin there has to be able to stretch quite dramatically.
Okay, so that's the skin. Going deeper, we hit the deep fascia. And this idea of compartmentalization.
Yes, this is fundamental. The deep fascia isn't just a simple wrapping layer. It sends down these partitions, these walls called intermuscular septa.
And these septa divide the limb, particularly the arm and forearm, into distinct sections or compartments.
Correct. And this isn't just neat anatomical packaging. It serves at least two really important functions.
Okay, what are they?
First, those septa provide extra surface area, more space for muscles to attach, which can contribute to strength and refined movement vectors.
Makes sense. And the second?
Clinically, this is huge. Those compartments act like barriers. They can help limit the spread of things you don't want spreading, like infection or a tumor, or even just localized swelling. Keeps it contained to some extent.
But that containment, the double-edged sword, isn't it? That leads us straight into compartment syndrome.
Precisely. When you get significant swelling inside one of these rigid compartments, maybe from a bad fracture, crush injury, or even after blood flow is restored to an ischemic limb.
The pressure just skyrockets inside that closed space.
Exactly. And the mechanism is simple physics, but the results are devastating. The rising tissue pressure overcomes the pressure in the capillaries.
So it squeezes the tiny blood vessels shut.
It decreases the perfusion gradient across the capillary bed. Basically, blood can't get in to deliver oxygen, and waste can't get out. It's microcirculatory strangulation.
And this is the absolute key point, the one drilled into anyone dealing with limb trauma.
You cannot rely on checking the main pulses.
Right. The sources are crystal clear on this. Peripheral pulses, like the radial pulse at the wrist, might feel perfectly normal.
Yeah, because the pressure buildup affects the tiny capillaries and venules first. The big arteries can often withstand much higher pressures initially, so a palpable pulse tells you almost nothing about the health of the tissue inside the compartment.
So what are the signs then? What are we looking for?
The classic signs are often remembered as the 6 Ps, but the most reliable, the earliest, and most critical is pain.
But not just any pain.
No, we're talking about severe pain. Pain that seems way out of proportion to the visible injury. And crucially, pain that gets dramatically worse when you passively stretch the muscles within that specific compartment.
So if you suspect forearm compartment syndrome, gently extending the patient's fingers or wrist would cause agony.
Excruciating pain, exactly. That passive stretch is a key diagnostic sign. Other Ps like pallor, paresthesia, pulselessness, paralysis, those are often later, more ominous signs. Don't wait for them.
Because the clock is ticking very fast.
Unbelievably fast. Muscle and nerve tissue are incredibly sensitive to ischemia. You've only got a matter of hours, maybe 4 to 6, before irreversible damage starts to set in. Muscle dies, nerves die.
And the treatment is?
Non-negotiable. Immediate, thorough surgical decompression, a fasciotomy. You have to open up that tight fascial compartment, lay it wide open to relieve the pressure and restore blood flow.
No time for messing around. It's a true surgical emergency.
Absolutely. Delay means permanent disability, nerve damage, muscle loss, potentially even limb loss. You have to understand it, recognize it, and act decisively.
Okay, a critical concept. Let's move from those layers to the underlying framework, the bones and joints, the scaffolding.
Right. Let's just quickly tick off the components. It's quite a list.
We start proximally, clavicle, scapula,
And the humerus in the upper arm, radius and ulna in the forearm,
then the wrist, 8 carpal bones.
followed by the 5 metacarpals in the hand itself.
And finally, the 14 phalanges making up the fingers and thumb.
Add them all up.
32 bones. That's a lot of moving parts in one limb.
It is. And it all starts with the base, the pectoral girdle. That's the clavicle and scapula, linked by the acromioclavicular or AC joint.
And the really interesting thing here, structurally, is how loosely it connects to the rest of the skeleton, the axial skeleton.
Loosely is putting it mildly. The only actual bony joint connecting the entire upper limb girdle to the trunk is the sternoclavicular joint, where the collarbone meets the breastbone.
That's it, just that one joint.
That's the only bony articulation. Everything else, particularly the position and stability of a scapula, relies on muscles. Big, powerful, flat muscles.
Like
Trapezius holding it up from behind, serratus anterior pulling it forward around the chest wall, the rhomboids pulling it back, levator scapulae lifting the top corner. It's essentially a muscular sling.
which means its stability is dynamic, not static. It depends entirely on healthy muscle function.
Absolutely. And the sources make a point of this. If you paralyze those supporting muscles, say, damage the nerve to serratus anterior.
We'll get to that wing scapula later, I'm sure.
We will, but the point is, it doesn't just weaken movement, it destabilizes the entire base of the limb. The whole system's function is compromised because that crucial scapulohumeral rhythm is lost.
Okay, so a mobile but dynamically stable base. Now, the joint that gives us most of that mobility, the glenohumeral joint, the shoulder joint proper.
Right, a classic synovial joint. You've got the big round head of the humerus articulating with the, well, surprisingly shallow glenoid fossa of the scapula.
Shallow is the key word there. Great for movement, terrible for inherent bony stability.
Precisely. It's like a golf ball sitting on a tee, so it needs help staying put.
Part of that help comes from the glenoid labrum.
Yeah, that little fibrocartilage rim around the edge of the fossa. It does deepen the socket slightly, maybe increases the surface area a bit, helps with the suction seal.
And the capsule, where does that attach?
Immediately, it attaches around the neck of the glenoid. Laterally, it attaches out onto the anatomical neck of the humerus.
Okay, and inside that capsule, there's a really important structure we need to highlight.
Ah, yes, the supraglenoid tubercle. It's just a little bump on the scapula, right above the glenoid fossa.
But its significance.
It's the attachment point for the long head of the biceps tendon. And crucially, this attachment is inside the joint capsule. It's intracapsular.
Which explains why biceps tendon problems often feel like shoulder joint pain. It's right in there.
Exactly. Pathologies are closely related. Now, the main stabilizers, dynamically speaking,
The rotator cuff.
the rotator cuff, 4 muscles and their tendons blending with the joint capsule, supraspinatus on top,
Infraspinatus and teres minor behind.
and subscapularis in front.
And their job isn't just rotation, is it?
Not primarily, no. Their collective crucial function is to actively pull the humeral head into the glenoid fossa. They compress and center the joint during movement, providing that essential dynamic stability the shallow bones lack.
Okay, let's move down the arm to the elbow complex. Quite a different setup from the shoulder.
Very different. We shift from maximum mobility to more constrained but still complex motion. You've basically got three articulations working together.
The hinge joint.
The main one, between the humerus and the ulna, the trochlea and trochlear notch, that gives you flexion and extension.
And two pivot joints.
Right. One between the humerus and the radius, capitulum and radial head, which allows some rotation. And the really important one for forearm rotation, the proximal radial knot joint.
Where the head of the radius spins within a ring formed by the ulna's radial notch and a special ligament.
The annular ligament, that's the star here. It wraps around the radial head, holding it snugly against the ulna, allowing it to pivot freely.
And that pivot, combined with the distal radial reader joint, is what gives us that full 180 degrees or so of pronation and supination, turning the palm down and up.
Exactly. While the main hinge joint allows flexion from fully straight 0 degrees up to about 150 degrees, the whole complex is stabilized by a tough fibrous capsule and strong collateral ligaments on either side the radial and ulnar collaterals.
Okay. Below the elbow, we have the two forearm bones, the radius and ulna, running parallel. How are they linked?
They're connected by what's called a syndesmosis.
Yeah.
There's the oblique cord near the top, which is a bit enigmatic. Its exact function isn't totally clear.
But the main connection.
The interosseous membrane. This is a strong fibrous sheet filling the gap between the radius and ulna for most of their length.
And its structure is important.
Very. The fibers run obliquely downwards and medially from the radius to the ulna.
Why that direction?
It's thought to be crucial for transmitting forces. When you push up through your hand, the force mainly comes up through the radius at the wrist. That oblique pull in the membrane transfers some of that force across to the ulna.
Which then transmits it up to the humerus at the elbow. So it distributes the load.
Exactly. It also provides a large surface for deep muscle attachments. And critically, along with the radial head being captured by the annular ligament, this membrane strongly resists the radius sliding upwards relative to the ulna.
Which is clinically relevant in certain types of forearm fractures, right? Like Galeazzi or Monteggia injuries, where that linkage is disrupted.
Precisely. Preventing proximal radial migration is a key role.
Okay, down to the wrist now, the radiocarpal joint. What type of joint is this one?
It's classified as a synovial ellipsoid joint. It's important to note it's not a simple hinge.
Ellipsoid means it can move in two planes, flexion extension and abduction adduction.
Correct. It involves the distal articular surface of the radius.
But not the ulna directly.
Not directly. There's a complex structure called the triangular fibrocartilage complex, or TFCC, that sits between the ulna and the carpals. It acts like a cushion and stabilizer on the ulnar side.
So distal radius, TFCC, and then the first row of carpal bones.
The proximal carpal row. Scaphoid, lunate, and triquetrum. Those three articulate directly in the radiocarpal joint.
And the ligaments here. Any functional bias?
Yes,
Lab.
definitely. The ligaments on the palmar volar side, the palmar radiocarpal and ulnocarpal ligaments, are significantly thicker and stronger than the dorsal ones.
Which makes sense functionally, right?
Yeah.
Most heavy lifting and gripping loads the palmar side of the wrist.
Exactly. It needs that robust support. Movement-wise, you get about 140 degrees total flexion extension and maybe 70 degrees of combined radial and ulnar deviation, abduction adduction.
Now, inside the hand itself, the carpus, those 8 small bones are arranged in 2 rows.
They are. The proximal row we just mentioned, scaphoid, lunate, triquetrum, and sitting just on the front of the triquetrum is the little pisiform bone.
Okay, and the distal row.
Moving from the thumb side across, trapezium, trapezoid, capitate, the big one in the middle, and hamete with its distinctive hook.
And there's a joint between these 2 rows.
Yes, the midcarpal joint. It allows for additional movement, contributing significantly to overall wrist flexion and extension.
Then we get to the joints connecting the carpals to the metacarpals, the carpometacarpal or CMC joints. The thumb CMC joint is special.
Extremely special.
Yeah.
The first CMC joint between the trapezium and the first metacarpal is a saddle joint.
Like 2 saddles sitting on each other at right angles.
Precisely. And that unique shape is what allows the incredible range of motion of the thumb, particularly opposition, the ability to bring the thumb across the palm to touch the fingertips. That's fundamental to human dexterity.
What about the other CMC joints, 2nd to 5th?
They are synovial ellipsoid joints. They have less movement than the thumbs, but their mobility increases as you go towards the little finger side. The 5th CMT joint is the most mobile of these 4.
Allowing the hand to cup or adapt its shape.
Yes, helps conform the palm around objects. Then distally, you have the metacarpophalangeal, MCP, joints the knuckles. They're almost bicondylar, allowing flexion extension and also some abduction adduction, spreading the fingers.
And finally, the interphalangeal IP joints within the fingers and thumb.
These are pure uniaxial hinge joints, just flexion and extension. The thumb has one IP joint. The fingers each have two, the proximal PIP and distal DIP, interphalangeal joints.
Right, that's the complete bony and articular framework. A complex scaffold. Now let's power it up. The muscle's the engine. Where do we start? Back at the base.
Makes sense. Scapular suspension and motion. Before the arm can move effectively, the scapula needs to be positioned and stabilized.
So which muscles are key for just holding it there, suspending it?
The trapezius is huge, both stabilizing and suspending via its upper fibers. Pectoralis minor, coming from the ribs up to the coracoid process, helps depress and protract it. And the small subclavius muscle helps anchor the medial clavicle. All this maintains the integrity of that space under the acromion, the coracoacromial arch.
And for moving the scapula?
Levator scapulae lifts the top inner corner. The rhomboids, major and minor, pull the medial border back towards the spine retraction.
And the big one for forward movement?
The serratus anterior. This muscle wraps around the side of the chest wall, underneath the scapula, attaching along its whole medial border. When it contracts, it pulls the scapula forward and rotates it protraction. Essential for reaching, pushing, punching. Critical for lifting the arm overhead properly.
And this brings us to that clinical sign you mentioned earlier.
Ah, yes, serratus anterior paralysis. Usually from damage to its nerve, the long thoracic nerve, which has a long, vulnerable course.
What happened?
You get the classic winging of the scapula because serratus anterior normally holds the medial border flat against the chest wall. Without it, the border lifts off and sticks out, especially when the person pushes against something like a wall.
And functionally?
Big problems. The person can't effectively protract, and crucially, they lose the upward rotation of the scapula needed for full arm elevation. They often can't lift their arm much beyond 90 degrees and sustain it.
A really debilitating injury. We should also note, the sources specifically exclude the sternal head of pectoralis major as a primary scapular mover.
That's right. While its actions on the humerus might indirectly influence scapular position, it's not grouped with the muscles whose main job is scapular motion.
Okay, now muscles acting directly on the shoulder joint itself. The sources group these conveniently.
Yes, into three groups based on origin. Group 1 originates from the axial skeleton, the trunk. Think big, powerful muscles.
Like pectoralis major, its sternal head, and latissimus dorsi coming off the back.
Exactly. These are major movers of the humerus relative to the trunk. Group 2 originates from the shoulder girdle itself, the clavicle, and scapula.
So the deltoid, the clavicular head of pectoralis major, coracobrachialis.
Right. These move the humerus relative to the scapula. And group 3.
The rotator cuff. We met them earlier as stabilizers.
We did. Subscapularis for internal rotation, infraspinatus and teres minor for external rotation, and supraspinatus mainly initiating abduction, lifting the arm out to the side. But remember their primary role, dynamic stabilization, centering that humeral head.
And when that centering mechanism or the space available fails, we run into problems like impingement syndrome.
Exactly. This relates directly to that confined space we mentioned, the subacromial space.
Sandwiched between the rotator cuff tendons below and the rigid coracoacromial arch, acromion, coracoacromial ligament, AC joint above.
Correct. Normally there is a bursa in there, the subacromial bursa, often continuous with the subdeltoid bursa laterally, which is like a little fluid-filled cushion to allow smooth gliding.
But what goes wrong in impingement?
Several things can happen. The arch itself might become roughened or develop bony spurs, often from degenerative changes in the AC joint. Or the rotator cuff tendons themselves might become inflamed or swollen, maybe after an injury or overuse.
So either the ceiling gets lower or the contents get thicker. Either way, there's less space.
Precisely. And then when you try to lift your arm, especially during abduction, those inflamed tissues or the roughened bone surfaces rub against each other. The bursa gets inflamed bursitis. The tendons get irritated, tendinitis.
Causing pain. Is there a characteristic pattern?
Very much so. The classic symptom is a painful arc of movement. The pain typically comes on as they abduct the arm, usually worst somewhere in the middle range, maybe between 60 and 120 degrees, and then might ease off again if they can get the arm fully elevated.
How is it treated?
Initially, conservative measures like rest, anti-inflammatories, and physical therapy. An injection of local anesthetic and corticosteroid into the subacromial space can be very helpful.
How does the steroid help?
It powerfully reduces inflammation in the bursa and tendons, relieving the pain. But it's important to remember it doesn't fix the underlying mechanical problem, like a bone spur. It just calms the fire.
So if it keeps coming back, or the mechanical issue is severe.
Then surgery might be needed, a subacromial decompression. The surgeon essentially goes in and shaves away some of the undersurface of the acromion, maybe removes any spurs, sometimes resects the outer end of the clavicle if the AC joint is the culprit. The goal is to physically create more space.
Make more room for the cuff tendons to glide freely. Okay, moving down to the muscles acting across the elbow. Much simpler here. Mainly flexion and extension.
Primarily, yes. The main flexors are in the anterior compartment of the arm. Bicep brachii is the most prominent.
Two heads, hence biceps. We already noted the long head starts inside the shoulder joint.
Correct. Biceps is a strong flexor, but it's also the most powerful supinator of the forearm, especially when the elbow is flexed. Think using a screwdriver.
And its nerve supply.
Musculocutaneous nerve, primarily from C5 and C6 nerve roots.
Lying just deep to the biceps is another flexor.
Yes, the brachialis. This is the workhorse flexor. It attaches to the ulna, so its only job is to flex the elbow, and it does so powerfully regardless of whether the forearm is pronated or supinated. Also supplied by the musculocutaneous nerve, maybe a little contribution from the radial nerve sometimes.
Okay, that's flexion covered. Extension is simpler.
Much simpler. The posterior compartment of the arm contains only one muscle group, the triceps brachii.
Three heads this time. Long, lateral, and medial.
Exactly. It's the principal extensor of the elbow. Its nerve is the radial nerve, C6, C7, C8. Interestingly, the sources note that each of the three heads typically receives its own separate branch from the radial nerve, suggesting quite refined control.
And the long head has a proximal attachment on the scapula.
Yes, on the infraglenoid tubercle, just below the glenoid fossa. So it can also help weakly extend the shoulder.
Right, now into the forearm. Lots of muscles here, tightly packed into compartments again. Let's start with the flexor side, the anterior compartment. It's layered.
Very much so. The superficial flexor compartment contains several muscles originating largely from the medial epicondyle of the humerus, the common flexor origin.
Which ones are in this layer?
You've got pronator teres, which primarily pronates the forearm. Then flexor carpi radialis, flexes and radially deviates the wrist. Palmaris longus, variable, weak flexor, often harvested for tendon grafts. And flexor carpi ulnaris, flexes and ulnarly deviates the wrist. These all lie superficial to the next layer down. Flexor digitorum superficialis, FDS. This muscle then splits into four tendons to flex the IP joints of the fingers. Beneath FDS, we find the deep flexor compartment.
Okay, what's in the deep layer?
Three muscles here. Flexor digitorum profundus, FDP, its tendons run all the way out to the fingertips to flex the DIP joints. Flexor pollicis longus, FPL, the main flexor of the thumb. And pronator quadratus, a square muscle deep at the wrist that assists with pronation.
Now, there's a really critical detail about the FDP innervation. It's not simple.
No, it's fascinating and surgically vital. The FDP muscle belly is essentially split in two, functionally speaking.
How so?
The parts of the muscle going to the little and ring fingers are supplied by the ulnar nerve, but the parts going to the middle and index fingers get their supply from the anterior interosseous nerve, which is a branch of the median nerve. The root values are typically C8 and T1.
So a dual nerve supply within the same muscle, controlling different digits.
Yeah. It likely reflects the different functional roles. The ulnar side of the hand is more involved in power grip, controlled by the ulnar nerve. The radial side, index, and middle fingers are crucial for fine pincer grip and precision movements, which falls under the median nerve's territory.
So if you have an injury high up affecting only the median nerve, you'd lose FDP function just in the index and middle fingers.
Precisely. The patient wouldn't be able to make a full fist. They couldn't flex the tips of those two fingers. It's a classic clinical sign demonstrating this specific innervation pattern.
Amazing detail. Okay, let's flip to the back of the forearm, the extensor compartments. Also layered.
Yes, superficial and deep again. The superficial extensor compartment arises mainly from the lateral epicondyle, common extensor origin.
What muscles are we talking about here?
You have the small anconeus at the elbow, brachioradialis, which is functionally more of a flexor but sits in this compartment anatomically. Then the main extensors of the wrist, extensor carpi radialis and brevis, extensor carpi ulnaris, and the common extensor of the fingers, extensor digitorum, plus the extensor for the little finger, extensor digiti minimi.
And their innervation.
It's primarily the radial nerve, either directly or via its superficial branch before it becomes purely sensory, and also the posterior interosseous nerve for some. It's a bit mixed in the superficial layer.
But the deep extensor compartment is different.
Yes, functionally distinct muscles here. You've got the supinator muscle, which wraps around the radius to help supinate the forearm. Then the muscles dedicated to the thumb abductor pollicis longus, extensor pollicis brevis, these two form the radial border of the snuff box, and extensor pollicis longus forms the ulnar border. And finally, extensor indicis, giving independent extension to the index finger.
And the innervation for all of these deep muscles.
This is clear-cut. They are all supplied solely by the posterior interosseous nerve, PIN. That's the deep, purely motor branch of the radial nerve after it divides.
So an injury specifically to the PIN would knock out supination in all thumb and index finger extension, but might spare wrist extension if the more superficial muscles are innervated higher up.
Exactly. It highlights the importance of knowing these precise branching patterns.
Okay, that covers the forearm engines. Finally, the fine-tuning muscles located entirely within the hand, the intrinsic muscles.
Yes, these are crucial for dexterity. We have the lumbricals first, unusual origin.
They arise from the tendons of FTP, the deep flexor.
Correct. 4 of them. They pass anterior to the MCP joints but insert onto the extensor hoods on the back of the fingers. Their main action is complex, but functionally they help extend the interphalangeal IP joints, especially when the MCP joint is extended. Think flattening the fingers. They are key for that precise pulp-to-pulp pinch.
Then the interossa. 2 groups.
Yes, palmar and dorsal. There are 3 or 4 palmar interossae. Sometimes the first is absent or fused. Their job is adduction, bringing the fingers towards the middle finger, PAD.
And the dorsal interossae.
4 of these located between the metacarpals. They abduct the index, middle, and ring fingers away from the midline of the hand, DAB. Both sets of interossae also help flex the MCP joints and extend the IP joints via the extensor hoods. They provide lateral stability to the fingers.
Now, the innervation of these intrinsics is another area needing mastery. It's mostly one nerve, but with critical exceptions.
Overwhelmingly, the intrinsics are supplied by the ulnar nerve, specifically its deep motor branch. This includes all the interossae, the 2 ulnar lumbricals, 3rd and 4th, and the muscles of the hypothenar eminence, little finger side.
But the median nerve handles some crucial ones.
Absolutely critical ones for thumb function. The recurrent motor branch of the median nerve, which curves back into the thenar eminence, thumb base, invariably supplies the abductor pollicis brevis, key thumb abductor, the opponens pollicis, the muscle that brings the thumb across for opposition, and usually the superficial head of the flexor pollicis brevis.
And the lumbricals.
The median nerve typically supplies the 1st and 2nd lumbricals, index and middle fingers, and sometimes the 3rd.
So that recurrent branch of the median nerve is functionally priceless.
Absolutely. An injury to just that small branch, maybe from a cut at the base of the thumb, can devastate hand function by taking out opposition. It really highlights the median nerve's role in fine precision thumb movement.
Okay, we've built the structure and powered it. Now the infrastructure, blood supply, and drainage. Let's trace the arteries.
Start centrally. The subclavian artery is the source. On the right side, it comes off the brachiocephalic trunk. On the left, directly off the aortic arch.
Any key branches right at the start we should know?
The first part gives off some major ones. The vertebral artery to the brain, the internal thoracic artery supplies the chest wall, and the thyrocervical trunk supplies neck and shoulder structures.
When does it change names?
As it passes over the lateral border of the first rib, it becomes the axillary artery.
And this artery is divided conceptually.
Yes, into 3 parts, based on its relationship to the pectoralis minor muscle, which crosses over it. Part 1 is medial to the muscle, Part 2 is deep to it, Part 3 is lateral to it. This is really useful shorthand for describing where branches originate or where pathology is located.
Okay. When does it become the brachial artery?
At the lower inferior margin of the teres major muscle, the brachial artery is then the main artery of the upper arm running down the medial side.
Does it have important branches for collateral circulation around the elbow?
It does. It gives off profunda brachii deep in the arm and near the elbow, superior and inferior ulnar collateral arteries. These anastomoses connect with recurrent arteries coming back up from the radial and ulnar arteries in the forearm. It creates a network that can bypass the main channel if needed.
Then, just distal to the elbow crease, the brachial artery divides
into its 2 terminal branches, the radial artery laterally and the ulnar artery medially.
The radial artery is the one we feel for a pulse at the wrist.
Yes, it runs quite superficially there, just lateral to the flexor carpi radialis tendon, deep to brachial radialis. The ulnar artery runs deeper in the forearm, giving off a major branch near its origin.
The common interosseous artery.
Correct. This artery quickly dives deep and divides again.
Into anterior and posterior interosseous arteries, following the interosseous membrane.
Exactly. The anterior interosseous artery, AIA, runs down the front of the membrane between FDP and FPL. It has one particularly important named branch.
The median artery.
Yes, the artery to the median nerve, or a median artery. It's the primary blood supply to the median nerve itself in the forearm. Very important clinically.
What happens to the AIA distally?
It gives off branches to the deep muscles, then pierces the interosseous membrane near the wrist to head dorsally.
And this is where we need that precision point from the sources. It joins.
It anastomoses with the posterior interosseous artery and then contributes to the dorsal carpal arch on the back of the wrist. It does not pass under the extensor retinaculum to join the palmar arch directly. That's a common misconception the source corrects.
Got it. What about the posterior interosseous artery, PIA?
After branching from the common interosseous, it passes dorsally over the top edge of the interosseous membrane, then runs down the back of the forearm between the superficial and deep extensor muscles supplying them. It eventually reaches the dorsal carpal arch, too.
Okay, so that covers the forearm supply. In the hand, it culminates in the palmar arches, 2 of them.
Yes, the superficial and deep palmar arches. The superficial palmar arch is primarily formed by the continuation of the ulnar artery. It often gets a small contribution from a superficial branch of the radial artery.
And it gives off.
The common palmar digital arteries, which then split to supply the sides of the fingers.
And the deep palmar arch.
This lies deeper, across the bases of the metacarpals. It's formed mainly by the terminal part of the radial artery after it winds around the wrist dorsally and comes back into the palm. It's completed by the deep palmar branch of the ulnar artery.
What branches off the deep arch?
It gives off the palmar metacarpal arteries.
And these connect to the superficial system.
They do. The palmar metacarpal arteries run distally in the intermetacarpal spaces and anastomose with the common palmar digital arteries arising from the superficial arch. It creates a very rich interconnected blood supply to the hand and digits.
Okay, that's the supply line. What about the return journey? Venous drainage. Also 2 systems.
Yes, deep and superficial, mirroring the arteries somewhat. The deep veins are the vena comitantes. These are usually paired veins that closely accompany the major arteries, radial, ulnar, brachial, and share their names. They eventually merge as they go proximally.
To form.
The axillary vein, usually formed by the joining of the brachial veins and the basilic vein.
Ah, so the basilic vein is part of the superficial system, but joins the deep system. Let's trace the superficial ones. Where do they start?
They start from a network on the dorsum of the hand, the dorsal venous arch. 2 main veins arise from this.
The cephalic and basilic veins. Which is which?
The cephalic vein runs up the lateral radial side of the forearm and arm. It stays superficial for a long time, running in the delta pectoral groove near the shoulder, before diving deep near the clavicle to drain into the terminal part of the axillary vein.
Yeah, the basilic vein.
Runs up the medial ulnar side of the forearm. About halfway up the upper arm, it dives deep to join the brachial vena comitantes, and together they effectively become the axillary vein.
So the basilic is a major contributor to forming the axillary vein. What about that vein in the elbow crease we always use for blood tests?
That's the median cubital vein. It's a variable but usually prominent connection running obliquely across the antecubital fossa, linking the cephalic and basilic veins. Very accessible.
Okay, so the deep and superficial systems collect into the axillary vein. What happens next?
The axillary vein continues towards the chest. As it crosses the outer border of the first rib, same landmark as the artery, it becomes the subclavian vein.
Okay.
The subclavian vein then joins the internal jugular vein, draining the head and neck, behind the sternoclavicular joint. And this union forms the large brachiocephalic vein, also called innominate vein.
And the 2 brachiocephalic veins, left and right, merge to form the superior vena cava, draining into the heart. Got it. What about lymphatics?
Lymphatic drainage generally follows the veins. You have superficial vessels following the superficial veins, cephalic and basilic, and deep vessels following the deep veins and arteries within the neurovascular bundles.
Where do they all ultimately drain?
Regardless of whether they start superficial or deep, essentially all the lymphatic drainage from the upper limb eventually converges on the axillary lymph nodes located in the armpit. They were typically grouped lateral, pectoral, subscapular, central, apical.
Particularly the lateral group initially.
Yes, the lateral axillary nodes lying along the axillary vein receive most of the direct drainage from the limb itself. From there, lymph flows through the other axillary groups towards the apex.
And the final outflow.
From the apical axillary nodes, lymph drains into the subclavian trunk. On the left side, this usually empties into the thoracic duct, the main lymphatic channel in the body. On the right side, the right subclavian trunk typically drains directly into the large veins at the junction of the internal jugular and subclavian veins.
Okay, complex plumbing. Now, the wiring that controls it all, the brachial plexus, where does it come from?
It's formed from the anterior primary rami, the main front branches of spinal nerves, C5, C6, C7, C8, and T1. These are the roots of the plexus. Sometimes there are small contributions from C4 above or T2 below, mostly supplying skin near the boundaries.
Does anything branch off right at the root level?
Yes, a couple of important motor nerves. The dorsal scapular nerve comes off the C5 root and supplies the rhomboid muscles and levator scapulae.
And the other?
The long thoracic nerve, formed from contributions from C5, C6, and C7 roots. It runs down the chest wall to supply the serratus anterior muscle. We already know how crucial that is.
Before we get into the main cords and branches, there's one major muscle in the shoulder region with different innervation.
Ah, yes, the trapezius. Despite being a major scapular stabilizer and mover, it's not supplied by the brachial plexus.
It gets its motor supply from.
The accessory nerve, which is cranial nerve exliev, it might get some proprioceptive fibers from the cervical plexus, C3, C4, but the motor drive is cranial.
And that accessory nerve is vulnerable.
Very, especially where it crosses the posterior triangle of the neck. Surgeons exploring that area, for lymph node biopsies, for example, have to be extremely careful not to damage it. Injury leads to shoulder droop, weakness in shrugging, and problems with arm elevation because of poor scapular control.
Okay, back to the plexus proper. The roots combine to form trunks, the trunks divide, the divisions recombine to form cords. It's complex, but let's focus on the main terminal branches coming off the cords. The big three first: median, ulnar, radial.
Right. The median nerve is formed by contributions from both the lateral cord, from C5, C6, C7 roots, and the medial cord, from C8, T1 roots.
Giving it root values C5, T1 effectively. Though C5 is sometimes minor or absent, mostly C6, T1.
Typically C6, T1, yes. Those two contributions, one from the lateral cord and one from the medial cord, often join together in front of the axillary artery, forming a characteristic M shape.
Key point about the median nerve in the upper arm.
No branches. It gives off nothing in the upper arm itself. It just travels down, usually alongside the brachial artery.
Its first branches arise near the elbow.
Yes, typically in the cubital fossa or just below. It supplies pronator teres, flexor carpi radialis, palmaris longus, and flexor digitorum superficialis.
Then it gives off that important motor branch we discussed.
The anterior interosseous nerve, AIN. This dives deep to supply flexor pollicis longus, the radial half index middle finger parts of flexor digitorum profundus and pronator quadratus. Remember, the AIN is purely motor.
What happens to the main trunk of the median nerve?
It continues down the forearm, usually between FDS and FDP, and then passes through the carpal tunnel at the wrist, deep to the flexor retinaculum.
To supply what in the hand?
Motor supply via its recurrent branch to those key thenar muscles. Abductor pollicis brevis, opponens pollicis, superficial head of flexor pollicis brevis, and usually the first and second lumbricals. Sensory supply is to the palmar aspect of the thumb, index, middle, and the radial half of the ring finger, and the nail beds on the dorsal side.
Making it very vulnerable to compression in the carpal tunnel.
Extremely. Carpal tunnel syndrome is very common. It can also be compressed higher up, for example, as it passes through the pronator teres muscle.
Okay, next major nerve. The ulnar nerve. Where does that come from?
It's essentially the direct continuation of the medial cord of the brachial plexus. Its root values are primarily C8 and T1, sometimes with a C7 contribution.
Its path in the arm is characteristic.
Yes, it runs down the medial side of the arm. About midway down, it pierces the medial intermuscular septum to enter the posterior compartment, sometimes passing through a fibrous tunnel called the arcade of Struthers. Then it famously passes behind the medial epicondyle of the humerus at the elbow.
The funny bone.
That's the spot
Like
that's
a
very superficial and vulnerable there. It then enters the forearm by passing between the two heads of the flexor carpi ulnaris muscle, often through another tight spot called the cubital tunnel.
What does it supply in the forearm?
Two muscles, flexor carpi ulnaris, FCU, and the medial half, ring, and little finger parts of flexor digitorum profundus, FDP.
And in the hand.
It supplies almost all the intrinsic muscles, except for those few thinner muscles and radial lumbricals supplied by the median nerve. So all interessi, the ulnar two lumbricals, the hypocanal muscles, all ulnar nerve via its deep branch. Its superficial branch provides sensation to the little finger and the medial half of the ring finger, both palm and dorsum.
So vulnerable points are the elbow, cubital tunnel, and also the wrist, Guillen's canal.
Correct. Ulnar neuropathy often manifests with sensory changes in the ulnar digits and weakness or wasting of the intrinsic muscles, leading to clawing of the ring and little fingers.
Right. Third big one, the radial nerve, origin.
It's the terminal continuation of the posterior cord of the plexus. It carries fibers from all the roots, C5, C6, C7, C8, T1.
Its path in the arm is also notorious.
Very much so. After leaving the axilla, it winds around the back of the humerus, lying directly against the bone in the spiral groove, or radial groove, deep to the triceps muscle.
What does it supply in the arm?
It supplies all three heads of the triceps muscle, the main extensor of the elbow, and contributes to brachialis and brachiradialis often.
That spiral groove location makes it vulnerable.
Highly vulnerable, particularly to fractures of the midshaft of the humerus. Compression or transection here is a common cause of wrist drop because you lose the extensors downstream. Also vulnerable to prolonged pressure, like Saturday night palsy.
After winding around, it comes back to the anterior side near the elbow.
Yes, it pierces the lateral intermuscular septum and runs between brachialis and brachioradialis. In front of the lateral epicondyle, it divides into its two terminal branches,
Which are?
the superficial radial nerve and the deep branch, which quickly becomes the posterior interosseous nerve, PIN.
Superficial radial is sensory only.
Yes. It runs down the forearm under brachioradialis, then emerges more superficially near the wrist to provide sensation to the skin on the dorsal aspect of the thumb, index, middle, and radial half of the ring finger up to about the PIP joints.
And the posterior interosseous nerve.
That's the motor branch. It dives deep, passing through the supinator muscle, another potential compression point, and then supplies all the muscles in the extensor compartment of the forearm that we listed earlier, except maybe brachioradialis and ECRL, which can get branches higher up.
So PN lesion, finger drop, and thumb extension loss. But wrist extension might be partly spared if ECRLB got branches directly from the radial nerve.
Exactly. That distinction is important.
Okay, those are the big three. What about the other main branches from the cords? Axillary and musculocutaneous.
The axillary nerve also comes off the posterior cord, just before the radial nerve. Its root values are C5 and C6.
It has a specific exit route from the axilla.
Yes, it passes posteriorly through a space called the quadrilateral space, bounded by teres minor, teres major, long head of triceps, and humerus, along with the posterior circumflex humeral artery.
What does it supply?
Two muscles, the deltoid, the big shoulder cap muscle, and teres minor, one of the rotator cuff muscles. It also provides sensation to the skin over the deltoid, the classic regimental badge area.
Vulnerable with shoulder dislocations or fractures of the surgical neck of the humerus.
Yes, very much so. Injury leads to paralysis of the deltoid, difficulty abducting the arm, and loss of sensation in that badge area.
And finally, the musculocutaneous nerve.
This arises from the lateral cord, root values C5, C6, C7. It characteristically pierces the coracobrachialis muscle in the upper arm.
And supplies.
The muscles in the anterior flexor compartment of the arm, biceps brachii, brachialis, and coracobrachialis.
Then what happens to it?
After supplying those muscles, it emerges laterally between biceps and brachialis and continues down into the forearm as a purely sensory nerve. The lateral cutaneous nerve of the forearm, supplying skin on the lateral aspect of the forearm.
Okay, that's a dense network of wires. How do we relate this back to the surface? Surface anatomy for the clinician.
Hugely important for examination and surgical planning. A lot of the shoulder girdle is surprisingly accessible to palpation.
Like the whole clavicle.
The entire clavicle, from the sternoclavicular joint medially to the acromioclavicular AC joint laterally, is subcutaneous. You can feel the SC joint, the step off at the AC joint.
And the scapula.
You can feel the entire spine of the scapula running across the back, leading out to the acromion process. The medial border is usually palpable, and the inferior angle is a key landmark.
Where's the inferior angle usually located?
typically around the level of the seventh rib or seventh thoracic vertebra spinous process. Also, the coracoid process is important. You can usually feel it deep in the infraclavicular fossa, about 2.5 centimeters or an inch below the clavicle towards the outer side, a key landmark for anterior shoulder approaches.
What about the humerus? More covered.
Mostly covered by muscles, yes, but you can often palpate the greater tubercle laterally, just below the acromion, especially if you rotate the arm. The lesser tubercle is more anterior. The shaft itself is deep, but you can sometimes feel it in the midarm through the brachialis, just in front of the lateral head of triceps.
And that's right where the radial nerve is lying in the spiral groove.
Exactly, a palpable reminder of its vulnerability there. Distally at the elbow, the medial and lateral epicondyles are very prominent landmarks. The medial one is usually sharper, more distinct.
Down in the forearm and wrist.
The posterior border of the ulna is subcutaneous along its entire length, from the olecranon process at the elbow down to the ulnar styloid at the wrist. A very useful bony landmark.
Pulses. We mentioned the radial artery.
Between the flexor carpi radialis tendon and the radial styloid. The ulnar artery pulse is harder to feel, it's deeper, but you can try just lateral to the flexor carpi ulnaris tendon near the pisiform bone. The ulnar nerve lies just medial to the artery there.
And the anatomical snuff box.
That depression on the dorsolateral aspect of the wrist when you extend your thumb, very important clinically.
Boundaries.
Radially, thumb side, it's bounded by the tendons of abductor pollicis longus, APL, and extensor pollicis brevis, EPB. Ulnarlarly, it's bounded by the tendon of extensor pollicis longus, EPL.
And its significance.
The floor of the snuff box is formed by the scaphoid bone and the trapezium. Tenderness, specifically in the snuff box after a fall, is highly suspicious for a scaphoid fracture, even if x-rays are initially negative. Also, the superficial radial nerve crosses the roof of the snuff box, making it vulnerable to injury from cuts or even tight wristwatches.
What about palpating the bones in the hand itself?
Dorsally, the metacarpals and phalanges are easily felt. Palmarly, they're obscured by the flexor tendons, palmar aponeurosis, and thick skin. But you can palpate some key landmarks around the wrist crease on the palmar side. The hook of the hamate medially, the pisiform bone slightly proximal to it, and the tubercles of the scaphoid and trapezium laterally, important for diagnosing wrist pain and locating structures.
Excellent, a thorough map. Now, briefly, let's rewind right to the beginning. The development of this complex structure, how does it start?
It begins very early in embryonic development, around the end of the 4th week, as limb buds. These are little outgrowths from the lateral body wall.
What triggers them?
Complex signaling interactions between the surface ectoderm, skin precursor, and the underlying mesenchyme, connective tissue, bone, muscle precursor, specifically the somatopleuric layer of the lateral plate mesoderm.
And these buds grow outwards, establishing axes.
Yes, they grow proximodistally, shorter to fingertips. They also establish a cranial or preaxial border, thumb side, and a caudal or postaxial border, little finger side, as well as dorsal and ventral surfaces.
Are there specific signaling centers controlling this?
2 key ones mentioned in the sources. The apical ectodermal ridge, AER, is a thickening of ectoderm at the very tip of the growing bud. Its length and signaling influence the proximodistal outgrowth, basically how many segments form, upper arm, forearm, hand.
And the other?
The zone of polarizing activity, ZPA. This is a cluster of mesenchymal cells located at the posterior border, little finger side, of the limb bud. It produces signals, like sonic hedgehog protein, that pattern the limb along the antero-posterior thumb to little finger axis, specifying digit identity.
So defects in AER signaling might lead to truncated limbs, while ZPA issues could cause things like polydactyly, extra fingers.
Exactly. These centers are critical organizers. Now, where do the different tissues come from?
Bones, joints, ligaments.
They differentiate from that core somatochloric mesenchyme.
But the muscles migrate in.
Yes. The limb muscles actually originate from the somites blocks of mesoderm lying alongside the developing mural tube. Specifically, cells from the dermomyotome part of the somites migrate out into the limb bud.
And they organize themselves.
They coalesce into a dorsal muscle mass, which will become the extensors and supinators, and a ventral muscle mass, flexors and pronators, already associated with the developing nerves.
Now, there's a fascinating detail about some shoulder girdle structures having a different origin.
Yes. The connective tissues associated with the trapezius and sternocleidomastoid muscles, muscles innervated by the accessory nerve, actually derive from neural crest mesenchyme. This is different from the mesoderm origin of the rest of the limb skeleton and connective tissues, a unique origin for that specific region.
Interesting. What's the rough timeline for visible development?
Stage 12, around 30-32 days, the limb bud is just a visible protrusion. By stage 15, you can start to identify a shoulder upper arm region and a flattened hand plate.
Ah,
Stage 17, around 40 days, elbow and forearm are discernible, and you can see condensations for the fingers, the digital rays within the hand plate. By stage 20, around 50 days, the main regions are clear and the fingers are starting to separate as the tissue between the rays undergoes apoptosis, programmed cell death.
what about the blood vessels? Where does that main artery come from?
The primary artery of the upper limb, the axial artery, develops from the lateral branch of the seventh intersegmental artery coming off the dorsal aorta. This single vessel differentiates along its length to become the subclavian, axillary, brachial, anterior interosseous, and ultimately contributes to the deep palmar arch.
And the superficial veins, cephalic and basilic.
They develop from precursor veins running along the edges of the limb bud. The preaxial marginal vein becomes cephalic, and the postaxial marginal vein becomes basilic.
Finally, the sources stress something absolutely crucial for normal development, something that happens throughout this process.
Yes, movement. Embryonic and fetal movements are not just a result of development, they are essential for the normal formation and maturation of the limb tissues.
How so?
Joint cavities don't form properly without movement. Muscle differentiation, tendon development, even the structure of the overlying skin and connective tissue are influenced by the mechanical stresses and strains generated by those early movements. It's fundamentally required.
So structure dictates function, but function, or at least early movement, also dictates structure.
Beautifully put. It's a dynamic interplay right from the start.
Okay, we've covered an immense amount of detail, aiming for that elite professional understanding. Let's try to synthesize the most crucial connections.
Agreed. For me, three things really stand out for high-level grasp. First, that delicate balance in the pectoral girdle. Its stability relies almost entirely on muscle function. You see serratus anterior palsy, and the whole foundation crumbles. It highlights the primacy of the muscular system for the limb space.
Second, the stark clinical reality of fascial compartments. Understanding that pressure, not just direct vascular injury, can cause devastating ischemia, and that palpable pulses are dangerously reassuring. That knowledge saves limbs. Compartment syndrome is non-negotiable.
Absolutely. And third, the sheer specificity of the neurovascular pathways. Knowing precisely where nerves like the radial or ulnar are vulnerable, the spiral groove, the cubital tunnel, and appreciating those intricate, sometimes dual innervation patterns like in FDP is key to diagnosing injuries and predicting functional loss.
It really shows the functional beauty, doesn't it?
Yeah.
This incredibly complex system where failure in one small component, a single nerve, the perfusion in one compartment, can drastically limit that whole sphere of reach we started with.
It does. Which brings us back to development and maybe a final thought for you, the listener, to ponder. We established that movement, driven by those developing nerves, is physically necessary for the limb's anatomical structures to form correctly in utero. We also mapped out today just how incredibly specific that final motor wiring is. Different nerve fibers controlling index versus little finger flexion, for instance.
Okay.
So the question is, what are the deeper implications of this early, required, neurologically guided movement? How much does that fundamental process influence the final, lifelong refinement and hardwiring of our fine motor skills? And, perhaps more critically, how might that deeply ingrained developmental link between movement and structure impact our potential for rehabilitation and functional recovery after major injury as an adult? Does that early foundation set limits or offer pathways for regaining complex function?
A profound question, linking development, structure, function, and recovery. Something to definitely mull over as you continue to master the intricate anatomy of the upper limb.